3 years ago, I concluded a very impactful academic research study where I answered the question, how did Cowessess First Nation develop and implement its Miyopima Act to retake control over its children? I found that years after the implementation of the Act, not a single Cowessess child was apprehended and placed into government child welfare. I had the opportunity to disseminate my research to thousands of people all over Canada and beyond. Amazing research is being conducted by Racialized faculty and graduate students all over Canada in fields from biology to psychology, from public policy to public health, from research in film to research in education. Racialized researchers are doing amazing work to solve real-life problems. And now they're here to share it with you in very simple terms. My name is Kwaku Ayisi, and this is Academic Research Made Simple. Welcome everyone to Academic Research Made Simple podcast. My name is Kwaku Ayisi. I am a PhD candidate at the Shoyama Graduate School of Public Policy here at the University of Regina. Incredible research is being done all over Canada by racialized faculty and racialized graduate students to solve real-world problems. Today we have an excellent researcher, Professor Ramona Kyabaggu, here to discuss her research with us. Ramona earned a BHSC in Health Information Management and an MSc in Information Sciences from the University of Western Ontario, Canada. She also holds an MSc specializing in epidemiology from the University of Aberdeen, UK, where she focused on digital epidemiology and pain research. She is currently pursuing her PhD in public health at the University of Saskatchewan's School of Public Health, focusing on projects related to the implementation of controlled substance e-prescribing and the development of a community substance use data platform. She's also currently Assistant Professor of Health Informatics and Information Management at the Shoyama Graduate School of Public Policy, Canada. Welcome to the ARMS podcast, Ramona. Good to have you here.
Thank you, Kwaku, for having me today. I'm excited about our discussion.
Wonderful, wonderful. So I'll start off with asking you to tell us a bit about your journey to become a professor and a PhD student.
Sure. So I would say that my journey is somewhat unique. I am trained in a field where there are not a lot of PhD qualified professionals across Canada. That is in health information management. Health information management professionals, I'm not sure if you're aware, are professionals that are responsible for all aspects of the life cycle of information across Canada. And so we've had, I think, an important role, particularly in clinical settings, although we're definitely expanding to other sectors and spaces as it relates to sort of that applied application. So bringing that applied application and sort of the theoretical footprint of this profession into graduate studies is actually, I would say, a watershed moment. For example, the program that we created at Shoyama Graduate School is the first master's degree level health information management program within Canada, albeit in other countries. And it's sort of emblematic of the fact that these countries are a little bit further ahead of us when it comes to things like digital health. In Australia and in the US, in the Mediterranean, the Middle East, and some places in Africa, there are actually graduate programs that preceded ours, including PhD programs. And so my background, it started with working in public health, actually. I worked in knowledge translation and program evaluation at different levels. So, some of my mandates were national. Some of my mandates were more local. And when the call came for a master's, this new master's program, I thought, well, this is the time to really apply and intersect in terms of the broader systems level, the health information management training that I have with what I had learned in public health, which is, again, much more population-based. And so I was working in practice for quite a bit of time, albeit my master's degree was actually trained you to be a researcher. I say I specialize in epidemiology because that's what the specialization was in. But everyone in the program was training to be researchers, and many of my colleagues are researchers in different institutions across the world. And so this was really an opportunity to bring to bear all of these different areas in which I had developed capacity to build something unique here.
Okay. Awesome. Would you say that your field falls under both public health and public policy, or is it just mainly public health?
If we're talking about health information management, certainly, obviously, the work I've done in public health and the PhD in public health is clearly under public health. But health information management is not restricted, I think, to public health. It's actually much more health. Currently, in its current configuration, is much more health care focused. And so it has more intersections with, I would say, public policy, certainly in the health administration aspects of it. Health information management professionals work and develop a lot of policies, but oftentimes they're working at the organizational institutional level, developing information policies. So information governance type policies, any of your e-health strategies or policies that you see, across the different jurisdictions in Canada, that's, privacy policies. That's where health information management professionals tend to find themselves. I think what we're trying to do at JSGS that is unique is we're trying to have them bring that expertise in those smaller P policies and to expand their capacity to bigger P policies. And we're seeing the need for that in this day and age, for example, with sort of the introduction of AI in many respects into our everyday lives. We're now having to, we should have been proactive, but we're now having to be at least responsive and to develop policies that protect populations in that way. So I think I would actually, if I had to choose, I'd be more likely to place health information management under public policy and healthcare. And that's, I think, why I see a need to develop out public health informatics perspectives more, because there's certainly a gap. And there's a priority that has been set by government to work in that area.
Okay.
Yeah.
Okay. Wonderful. So just as a follow-up to that, can you tell us also a bit more about just the general scope of public health, and for those who might not be very familiar, some of the different research work that is being done within the field of public health? Sure.
Public health is often sort of described as the little sister of healthcare, and certainly in terms of funding, if we look at the scale of the health care system and the activities that take place there. Public health is, I would say, the smaller entity of the two. However, it's so critically important, and we're quite aware of this. We should all be aware of this after what just happened in regards to the COVID-19 pandemic. So public health is really, it's about looking at the health of populations. So we're not just focused on sort of these acute care issues that are at the very individual level after you've developed a disease, but we're really interested in those upstream factors, including those social determinants of health that influence whether we might get a disease, or a population might have like a differential risk or something like that. Okay, in public health, it's really about the protection and the prevention, protection of health and the prevention of disease, right? We look at the distribution and determinants of that, I think more from like an epidemiological perspective of public health. But it's really, I think increasingly there's a lot of intersections with public policy, with folks really understanding the importance of engaging in policy processes, because policies are some of the most effective interventions in terms of, population health within our society. And so I would say I'm somewhat hesitant to put boundaries on what public health is, because I think, like even looking today, when we look at something like One Health, where we're thinking about the broader ecosystems, we're thinking about our relations to animals and all of what we perhaps would have defined public health as 10 years ago as opposed to today. I think the openness of public health to really look at, what are the different ways in which health is being impacted. To me, that's how I define public health, and being able to address those in a much more proactive and upstream way. Okay, excellent. Now let's talk a little bit. Now you've touched a bit on public policy, but let's talk about public policy also. I'm also in the field of public policy, and oftentimes
people who are not in public policy would ask, what is it all about? What do you mean by public policy? And sometimes I'll give them examples of an act that that is out there and the processes of developing that act, some of the recommendations that led to it, and how it is analyzed and why it's important. And so if someone were to ask you, what is public policy? What is considered public policy? How may you talk about that? And also you can connect it with public health as well.
Sure.
If you want to.
Yeah, I'll connect it to health information and maybe public health to some extent. So I'll tell you how I look at public policy, which is probably a little bit more narrow given that my field is so specialized. I look at public policy, I look at it from the evidence perspective, the ways in which we have dialogues and conversation, the discourse within our existing institutions, and how those are, I think, translated into policies that reflect social expectations and norms, but are also responsive to the needs of, like, say, communities or what the evidence is saying. So for me, as a health information professional whose information might make its way through the policies, it might be a part of either the dialogue or part of the evidence in a briefing note, or the analytics itself might be part of more data-driven decision making. I look at it as, the instruments that we use to govern a society, including the specific policies, like you said, the acts, the legislation. Certainly in my field, regulation is very big, like privacy, and the evidence that we bring to bear. And we do not limit that evidence to just the research evidence, to be honest. It's also, evidence of values and attitudes and, like I said, norms within society. To me, that's what public policy is. Of course, I recognize that's not all that it is, but from my perspective, it's very much bounded in the existing evidence and how we integrate and synthesize that to be able to make, I think, responsible and ethical decisions about how we govern our societies.
Okay.
So that, of course, that's going to have, those decisions are going to be public health based, but they're going to be in many other areas of our society. So it's not just public health, of course.
Yeah, absolutely. Yeah. Absolutely. Great. So now let's move to your research topic. How would you describe your research topic to a generalized, non-specialized, or non-technical audience?
So I would say what makes my research somewhat disruptive is I'm trying to take it out of just the space of the clinical setting in which e-prescribing was originally and is predominantly implemented in. So I am looking at that setting, don't get me wrong. But certainly the qualitative research is looking to go beyond that, to look at, can this innovation, this digital health innovation, be used to support community care, working with different service agencies and health and human services, and looking at issues such as safe supply, like opioid substitution therapy, just some other uses of how we could use certainly the controlled substances modules for more public health purposes.
Okay. So for e-prescribing, some of the benefits of it, I would assume, for accuracy as well, because sometimes it's a pharmacist might get a written prescription wrong, so it might be easier that way. Can you speak to maybe some of the other benefits of e-prescribing?
Sure. The errors are really important. Accuracy, and of course, especially with written notes, there's issues with legibility. So you completely eliminate those issues, right? Yeah. Certainly issues as it relates to efficiency, which are really important given the current congestion within our healthcare system, and wait times and the like. So if a prescriber and a dispenser are having to communicate back and forth over phone because they don't understand something, it actually creates a greater burden on our healthcare system, right, in terms of wait times and the like. There are other benefits when we integrate decision support, for example, detecting potential adverse harms that could happen. So I mentioned the idea of allergy alerts, but there are a range of other potential flags that could be identified when you start to connect the information that's within a pharmacy management system and the information that's within an electronic health record or electronic medical record system. So I think there are a lot of potential benefits. Certainly, if you go to Canada Health Info's website, Canada Health Info, that's a whole other discussion, and I think there's a lot of public policy considerations there. But Canada Health Info has really helped in terms of deploying a national e-prescribing system, working with individual governments. So, Canada Health Info works with deputy ministers across the country. And so they've done a really good job of gauging at least the perceived benefits of e-prescribing with those, end users. So that would be the clinicians, and that includes the pharmacists. Okay. So there's, if I were to go down the list of all the benefits, we would probably be here all day. Right. So if I miss something, I'm happy to speak to a certain area if you're interested.
Absolutely.
I think maybe, though, one more thing I would mention, and I really should have, is the jurisdictional assets that e-prescribing integrates with. So, drug dispensary information, for example, that might exist outside of the pharmacy management system or the EMR can now be also brought into play. So there's a certain level of interoperability that's enabled through e-prescribing, and this speaks to that coordination that I was speaking to. Okay. More interoperable information that we can now use to make better decisions.
Okay, great. Awesome. So in your research, and maybe if you've touched on this already, you can just expand on it. What would you say is the main issue, or if there's more than one, issues that you're trying to look more into and ultimately find a solution for?
Yeah, there are a few issues. I'll start, within the Saskatchewan context. We're really in an environment where there's the defunding of harm reduction, and we're moving towards more of a recovery-based model, which is more treatment-centric. And so a lot of the individual agencies at community level, human and health service agencies that are working with people who use drugs, they're moving, to like one-on-one needle exchanges, for example, or they're trying to find funds outside of government to be able to provide some of these harm reduction services. And so I think that's one issue that needs to be brought to bear, that context issue. I would say that another issue, which is more informatics based, and what brought me to this question, is the fact that this is a large implementation. If you go on Canada Health Info's website, you can see how many individual pharmacies. So we're talking retail pharmacies. We're talking, practices, clinical practices, group practices. It's a lot of the health care system that is being brought into this, and they're starting at the primary care level. So I'm not even talking about when they transition to acute care. And so what we found with some of these large implementations, given our current structure, different governments, different ways, regional ways in which they deploy softwares, it's really complicated. We're not talking about the NHS, where they are used to implementing one technology at scale across the country. We're talking about individual provinces with different priorities. I've mentioned how Saskatchewan has a different priority, trying to implement the same thing. And so what we found in the past with other implementations, the electronic health record in particular, is that we've moved a lot slower, and we've had a lot more failures and a lot more waste in terms of resources than perhaps we could have or should have. And so I'm interested in not just the sort of hard factors, but the soft factors that allow us to implement these technologies effectively. So that can include the implementation climate. Do clinicians, do prescribers feel that they are supported in implementing this technology? And that brings us back to, the resources within an organization, but also the overall governance and how entities like Canada Health Info are providing the governance supports to enable this to happen effectively. So it's about implementation. It is about looking at the effectiveness of it, because it is a hybrid study, but it's about how the ways in which we implement it well or not well impact how effective it is. That's really the question.
Right. Just as a follow-up to that, would you say learning and adoption, particularly for the end users, is also something you're considering?
Yeah. Yeah. So in my model, so we are using an existing model that is primarily, it's for the implementation of technologies, but is primarily used in, say, operations or business, and we're adapting it for healthcare. And one of the constructs in my model is implementation policies and practices, and these may be multi-level. So training is among the types of policies and practices that can improve the implementation climate, which mediates sort of an effective effective context for the technology to be used effectively. And when I say used effectively, I'm talking about things like actual behavioral use, because we can have a technology in place, but it's not being used to its fullest maturity. So we actually want we want the capabilities to be fully enacted and for people to be actually using the technology in their day-to-day practice.
Awesome. I know you've talked a bit about some of the context of the issue, but if there's anything else you want to add about the context or maybe the history of Canada's adoption and use of e-health systems as opposed to others. But also, what I also want to know is what are some of the findings that are in existing peer-reviewed literature regarding your topic or similar research that has been done?
A few things. If we're talking about e-prescribing, I won't get too much into the evidence in e-prescribing, maybe because I'm studying it, but there's a lot we can draw, I think, from our knowledge of electronic health record systems. So for e-prescribing, what we do know is that some countries are much more effective at implementing it very quickly, and other countries have taken decades. And in our country, we've taken decades to implement things like the electronic health record system or the Pan-Canadian electronic health record system. And that's because we made some mistakes that we are, I think, correcting. One of the mistakes that we made is we didn't start from the ground up. And that's what we're actually doing now with e-prescribing, or that's what InfoWay is doing now with e-prescribing, starting at the primary care level with community and really focusing on the needs of the prescribers and the needs of the dispensers in that setting. They make up the majority of those who will be using these systems. And so getting them on board, whether it's the innovation values that they associate with it, providing supports in terms of the financing to be able to implement these systems in place and have them in place. This is critically important. So with the electronic health record system, we did it differently. We're far more prescriptive in terms of what does the Pan-Canadian electronic health record look like in terms of the blueprints that were very common back then. And we were less focused on the governance. We were, more focused on, maybe acute care and less focused on community. And if we look at other jurisdictions, again, like the US, I would say Canada is like sort of in between, say, a UK and the US, because we benefit from the innovations that come from the US. And the US, when it comes to e-health systems or digital health systems, are very innovation driven. So because our markets are so intricately tied, a lot of the innovations that are made in the US actually come to Canada. And then we have to think about, usually it's simplifying them because the US health care system is so complex. How can we use a system that was designed for the US within Canada? So there's an innovation lens to the work that we do. But also we tend to have these bodies like Canada Health InfoWay that try to bring us into a more coordinated, more consistent, not just a competitive environment. So they're funding a lot of these systems. So they put constraints on what systems are funded if they meet certain criteria. So there's like certification programs, for example. So the vendors from the US, when they come to Canada, they have to make sure that it meets a certain threshold for what we need here in Canada. And then the government, or InfoWay, which is not the government exactly, but let's say arm's length, they then are able to release funds so that these things can be implemented effectively. What Canada has done wrong in the past is, and we're doing, like, I believe we're doing it with e-prescribing, but I shouldn't get ahead of my results. But in the past with electronic health records, say Obama era legislation, they really incentivized the adoption of technologies. And they didn't just say, okay, we're going to give you this technology and we're going to give you a bunch of money. You have to show that you're using it in meaningful ways. So they called it meaningful use. So that allows the country as a whole, even though there's all these different states with all these different innovations and different ways of delivering care, to still move towards a certain level of maturity, because every time they sort of reach that extra level, they get more funds. And this really made a difference for smaller hospitals. The larger private hospitals were already going in that direction. But, the teaching hospitals you'd be surprised, they didn't always pick up these technologies because they have other responsibilities. They're teaching the future, doctors. And so sometimes the latest technology and implementing it to its greatest maturity wasn't always the focus. Right. And so Obama era policies really made a big difference. And they're continuing that, particularly in the area of interoperability now in the US. Now Canada is doing it better. Looking at how other jurisdictions have done it and sort of making a more unique formula for us. And my instinct is that the way that e-prescribing is being done is going to be much more effective than the way we've done others. But again, you can't jump ahead of your results.
Yes. Regarding e-prescribing in a more electronic structure, where do you see, or can you talk about some of the opportunities and challenges when it comes to the use of data, particularly aggregate data for research to learn more about, maybe different illnesses, diseases, drugs?
Yeah, and I'm a little bit remiss that given that I am a health information management professional and I teach a lot about, like, say, administrative data sets in my class. Like, we use a lot of micro level data as it relates to the discharge abstract database. And we talk about knackers and I teach about coding. So this is my bread and butter in terms of teaching. And then when I go and do research, I'm doing it on information systems. And so I'm a little bit remiss that I am not doing more of this in my research, but it's a goal in the future, right? In terms of data, of course, I'm an advocate for data. The greater use of data, more open data. Certainly researchers need more access to linked data so we can ask more complex, wicked research questions, not just these siloed questions. I do think that there's a need for innovation, more synthetic data sets, which makes it easier to sort of, introduce, machine learning and AI and these sort of more discovery-based approaches on data that is going to be a little bit lower risk because everything about the structure of the data is the same, including sort of like the distributions that we would expect when we have this synthetically generated data, but we're also at the same time it's privacy preserving, right? And so I think there's a need for more innovation in that way. I think in Canada, we're starting to see that with the health, there's like a health data research network that is making it a little bit easier. But I think researchers have experienced a lot of barriers in getting access to the data, really lengthy ethics processes. Another area that I think we need to do, another sort of technique that we need to engage in more as researchers is, I think, having surveys, like doing our own research within a population and then linking it to, say, administrative data sets. And it's made very hard to do because we have this purpose use limitation, which is the data was collected for this purpose.
Yes.
So now you want to analyze it for another purpose. So jumping through all those hoops, I think is actually a barrier to us asking questions that I think are more representative of what we need to know in this day and age. So, it's very hard to say you've collected it for one purpose and to be able to answer a question that we need answered today for another purpose without having those barriers. Does that make sense?
Yes, absolutely. I completely get what you're saying because in the Saskatchewan Health Information Privacy Act talks about if you got to get consent anytime you're changing the purpose for which you collected information. As you rightly said, sometimes it's time sensitive, and you're going to go to 1,000 people and ask for consent over and over again. So on one hand, it's protecting their privacy rights, but sometimes it's difficult to work with in a timely fashion. So I completely get what you're saying.
Yeah, I would say also, I'd add, I would encourage people to look at what Europe is doing, the EU, because they're finding ways in which the individual citizen can share their data more, so they can give consent and they can revoke consent, and they can give consent to research questions that they're interested in and revoke it for ones that maybe don't align with their values. So they're actually providing what we would call it's infrastructure, but also the information infrastructure to enable that type of linkage of data, that multi-use data, and to also allow the individual client to feel empowered that, if I gave it for this one purpose, that's the only purpose I want it to be used for. But there are a lot of other people, because of the general good of research, generally we think when we answer research questions, or I shouldn't say answer, but when the research questions elucidate something really important about the way that we're doing something or the effect of an intervention, there's a downstream effect that is, it ends up benefiting patients. It ends up benefiting society as a whole in the long run. So there are a lot more people who are willing to share their information, but Canada really, I think, lacks that sophisticated consent architecture. So the actual architecture for people to be able to do it from their homes.
Right.
Yeah. Not from the place where they originally had their encounter and they gave their consent. And people change. And we have to recognize that people change, and maybe in one circumstance they wanted to give their consent, in another circumstance they didn't, and it can happen in the inverse.
Yes.
So we need the architecture for that to enable more sophisticated uses of data.
Absolutely. What are your research questions for the research that you're undertaking?
Yeah, and I've only given you a snippet because I would keep talking about the e-prescribing implementation, but in your introduction, you also spoke about like the data catalog. So maybe I can speak to that since I've spoken a lot about e-prescribing. So this is an integrative piece of work. So there's lots of different components, but I've started work with agencies, community service agencies, and we're hoping to continue this work. And they're really interested in developing a data platform. I can't speak too much about it, but I can say that they're interested in creating a data platform that would make it easier for them to share substance use data amongst each other. And the ultimate goal is really emancipatory. Considering the institutional requirements, like funding requirements for reporting, and how we're moving to, away from harm reduction, it really limits their ability to collect the data that would answer the questions as to whether the changes that we're making are actually perhaps making the system worse or better, right? It's because they're mandated to say, report on this. Their funder says, report on this. But they want to democratize that. They want to share the information that they're collecting, make more strategic decisions about what that might be as a group, as a whole. So they're coordinating their action, and to be able to use that beyond just the immediate service provision goals and the service reporting goals that they have, but for things like advocacy for reforms. Does that make sense?
Yes.
And so we have to, people, it's like we always want to talk about the big shiny object, like what I call like sexy tech. But we forget about all the things that need to be in place to support that. We need information governance. One thing. So we need to have governance frameworks and governance programs. So they need to be able to govern the information even before they develop the application of the technology. So that's one thing we're working on them with. And the other thing is, I'm very passionate about it because it draws on my information management. We're developing a metadata catalog. And we did some preliminary work with my students, which was really exciting because the students got to, start to categorize different substance use data, and it was a lot of fun. But we're going to take it to another level. We're going to create an open metadata portal. There's some decisions that have to come, so I don't want to jump too far ahead, but if we have an open metadata portal, everyone knows the data that everyone is collecting. We can start to have discussions about what is missing. or why are these organizations collecting this information and these aren't? I mean, I'm already starting to see trends anecdotally. The smaller, nonprofit organizations and the information that they collect relative to, like, say, a health authority. And, trying to get everybody on the same page in terms of collecting the most comprehensive and useful substance use data that they could. And then the next stage is, we're collecting substance use data, but we know that there's a relationship between that and, poverty or folks who are unhoused and all the other services that we're providing. So then you can start adding modules as you go along, and we can start answering more complex questions. Does that make sense?
Absolutely.
Yeah.
So the metadata catalog, is the scope national or?
No.
Okay.
Yeah. Sorry, finish your question.
No, I was just going to ask if it's national or it's regional, or how is it being collected?
Yeah, we're starting in Saskatoon.
Okay.
I would like you to think of it as more of a use case. So once Saskatoon does it, then Regina can do it, and others can do it, and then we start. And I think when I say institutions, I'm talking about governments. I'm talking about like funders. When they start to see this work that is happening, that's a little bit more grassroots. I think it provides an opportunity to integrate that and to scale it to, say, a provincial level. Does that make sense?
Absolutely.
But like I mentioned with the e-prescribing, a lot of times these types of innovations are very top down. You get a different product when it's bottom up. And we're already hearing from the agencies and some of the preliminary dialogues that we've had that, they're really interested in that upstream information, making sure that there's that equity and SDOH data really tied to the substance use data, right? Making sure that it's contextualized, making sure that even though we're moving towards more data-driven approaches, that we don't lose the storytelling, that we engage in data storytelling, right? And so that type of like consultation, that type of understanding the values of the community agencies on the ground, that happens like I mentioned from the bottom up. It's a little bit more organic. So I think our approach, you could see limitations to it, but I think the benefits will provide a really interesting use case.
Okay. So
I didn't talk about the methodology. You might get there.
But go ahead.
Sure. Yeah. I'll just speak to it just at a very high level.
Sure.
So a lot of the research that I do uses more of an agile approach, and a lot of I've sort of fallen in love with the agile approach, largely due to my collaborations in other projects, and engineering. There's folks in engineering, software engineering who are using this, and I'm like, I really like agile. So we're developing the different tools in a very iterative fashion. So we're not just saying like we're going to develop it like at a very stage-based approach, but okay, let's develop this part of it. What do you think about it? Oh, you don't like it? Well, let's go back to the first stage and let's remock that up and see how we can implement into like a minimum viable product, right? And so I'm using an agile design as my methodology for the actual design of those tools. Very collaborative and participatory, very iterative, consultative. You really need to understand the values. You got to map those values and integrate empathy into your approach, like empathy mapping, things like that.
Right.
But then alongside, we have a longitudinal institutional ethnography. So what that does is, as we're developing these tools, we want to evaluate the data work. So what are the meanings that people attach to the data work? So before we engaged with them in this way, maybe they thought it was a waste of their time. Maybe they thought it got in the way of the real work that they're supposed to do, right? Maybe they didn't feel very connected to it because the data that was being collected wasn't really representative of like I said, the stories that they wanted to tell about their clients. But as they're getting the opportunity now to participate in the design of the tools, how do they perceive that data work differently? And it's longitudinal because it's happening over time. We start with a situation where they do not have these tools at all, and what are the meanings that they attach to the substance use data then? During, as they're engaging in designing it, what do they attach to it? And then afterwards, when they have the tools in full fruition, and they can actually use it to maybe support their work in ways that are more systems level, or even just their everyday practice, like informing the evidence that they use in their practice. What are their impressions, their perceptions, and basically the meanings they attach to this data work.
Right.
Yeah.
Awesome. So there'll be some quantitative analysis and qualitative analysis as well. That's great. So I know you've talked about some of the limitations already. Are there any others, or did you cover it all pretty much?
Yeah, I think for me, the biggest limitation is trying to figure out where to position myself in the way that I've not from a positionality perspective. I have that very clear. From a where do I put my time in this project? Because we could hire developers, right? It's kind of hard when you have some technical expertise because you could actually build the tools, but it is my time, or am I going to be more impactful working directly with the agencies, facilitating, taking on more of a project management role? Or am I going to be more effective actually physically building the tools myself? Certainly the metadata catalog, I think it's a little bit too near and dear to my heart for me not to be involved in that build, but I really need to think strategically, and this will not be ultimately my decision. This is we'll put forth the limitations and the strengths of, how we resource this and let the agencies decide. But in my opinion, it's probably better to engage with software engineers or data architects to actually build out the platform. And we can be a part of that in different ways, but for continuity's sake and to ensure that we get the best product. So for me, it's about really stepping back and seeing, what questions do we want to answer? And where should I position myself in this work? Does that make sense?
Absolutely. Yes, it does. Why does this, and you've probably talked about this already, but again, to a broader audience, or let's even say maybe a 10 or 15-year-old who's asking why this matters for them as a general citizen or an end user of some of these systems and products.
Yeah.
How would you explain why it matters?
Thank you. E-prescribing, and I'll sort of put all the tools together, even though they're just slightly different research questions. E-prescribing, metadata catalogs, governance frameworks, and data platforms for sharing information on substance use are critically important because we're in the midst of a drug toxicity crisis. The reality is that people are dying every day. There is an issue, of course, with more potent drugs on the illicit market, and certainly we're even seeing the vestiges of that outside of health, and we're looking at like security and what are our values around there. So it affects all aspects of our society, right? Like in terms of national security. And so, from my point of view, it's critically important because this is, I think, one of the most important issues that we have within society, and how we approach it is going to be really important in terms of some of the most vulnerable, marginalized populations that, deserve equitable services. And so, yes, I'm like, when we talk about something like e-prescribing, it's in a clinical setting. And it doesn't have anything to do with fentanyl, but if you really look at it, it does. Because you are prescribed opioids, for example, and there's a whole trajectory towards how you can go from, pain, like my initial master's research was in pain, right? How you could go from something like, I've just had a surgery, and now I've got chronic pain, and now I need opioids, and before you know it, or opiates, and before you know it, you can't get them anymore, and now you're on the illicit. You're getting it in the illicit market, all right, or diverted use, and you're addicted. And after you're addicted, now you're getting access to these really high potent drugs, and this is happening to every it's happening every day to people across like all different intersections of our society, right? When I used to work, one of the last jobs I worked in community care was at a community a CHC in Ontario. And the work was just beginning. Like, we were looking at how can we improve intake processes and referral processes as it relates to Suboxone and methadone clinics. And so I really saw that like right head on during the opioid crisis within Toronto, in one of the most resource limited areas. That has sat with me as something that I feel I really want to have an impact in. Does that make sense?
Absolutely. It does. Great. So now the next question you can either answer on a personal level or maybe from a general perspective of what you've seen and heard. But as a racialized researcher and racialized PhD student, have there been and are there any barriers to success or opportunities available for success?
Yeah. I think there are opportunities. I was at some point a representative for the Canadian Black Scientists Network, which is a network of Canadians across Canada who work in STEM. And I thought this was a really innovative initiative in the sense that there were representatives in universities across Canada, and they were each within their own institutions, educational institutions, trying to implement different policies or different, trying to enact different resources that would support people like them, so other faculty members, but also their graduate students, so that research can be done. And the research that they were promoting was not just research about racialized populations. It wasn't just research that sort of reflects on, inequities or deficits that Black Canadians might experience, but also any kind of research. Like we want Black faculty and Black students doing really impactful, meaningful research and having the funding to support it, right? Having the mentorship that they would need, especially, one area that we really looked at that time was, and I'm sure this work is continuing, really focused on, new immigrant Black students. And the supports that they need, integrating into Canadian society and the challenges that come with that. And then also at the same time having to do, research that's going to set their future up, whether they become an academic or if they work in industry, right? So I thought that was a really critical support at more of a systems level that was very networked based. And I encourage folks to go to their website. There are incredible Black researchers across Canada who are willing to share their time. They're willing to share their resources. They want to share the work that they're doing and to bring you. And they have a conference. You can literally go to a conference where every research project that you see is led by a Black researcher. So definitely go to CBSN's website. So bringing it now back to University of Regina and outside of this particular organization of CBSN. As a racialized, I feel sometimes a responsibility when it comes to Black students, in terms of mentorship, and sort of that relational aspect, that you can do it. I'm here doing it right now. It's definitely something that is accessible to you. I also feel that, my racial status impacts on the questions that I ask. And it really, again, I didn't talk to my positionality in the work that I do, but it really should. From a data perspective, I'm interested in intersectional approaches, right? I'm interested in making sure that we don't average out those effects that are happening in our communities. From a data governance perspective, I'm really interested in making sure that Black communities are having a say in how, race-based data is being integrated into existing systems, or, whether that's our health system or whether that's an electronic system. So these are really important to me. So I try to make sure that these questions are being asked. Even if it's not the primary question, it can still be like a tertiary question, which makes the research harder and longer, and consultation and participatory approaches make for a longer timeline or trajectory to research. But I think it's research that we can more easily uptake and is more transferable because we've actually considered all the people that should be reflected in it. Does that make sense?
Absolutely. Maybe longer, but also creates more value for more people.
100%.
Yeah.
I like that. I like that perspective.
Yeah. Awesome. So you talked a bit about open research before, which is great, which is sort of in line with my next question. The government of Canada is committed to making federally funded science open by helping to generate research ideas, making data and publications readily available, and making research understandable and useful. Is there anything else you want to share in terms of maybe what you know about open data, like for example, open access publications, open peer review processes. If you've heard about that also, what do you think, or is there any more light you can throw on open research and open science?
Yeah, I think access is like, there's so many dimensions to access. So I'm probably going to start, because I used to work in KT in public health. I'm probably going to start with access to research knowledge, like the actual translation of that knowledge to community so they can actually use it in their everyday practice. I wrote a paper that relates to sort of like critical health literacy. And critical health literacy is not just about understanding like health concepts, but it's about how we use our understanding of the research or the evidence or let's say knowledge writ large, how we use that to empower our communities, to be able to engage in decision making. And so I think it is really important that access includes the tools that we create to democratize the information for everyday individuals. So having research behind paywalls doesn't help with access, right? I worked in public health, so I worked in an evaluation position. So a lot of times when I needed to access research, I would use, say, like an old, like say if I had an affiliation with the university, I wasn't able to get that in my everyday work, and yet I was evaluating programs. So we have these paywalls that like make it harder for the general public as well as the practitioners who are actually doing the work to know the best available evidence. To me, that doesn't make any sense. And again, I used to work with the National Collaborating Centers, and certainly shout out to the National Collaborating Center for Methods and Tools. This is critically important. Okay, so putting that question aside, so like open peer review processes. I think from my perspective, from what I know, in terms of open peer review processes, I think we need to engage more representation from actual, like say, patients or citizens. So they are, really looking at how looking at the results from their lens. So for me, I guess that isn't peer review, right? Because peer review would be somebody who's your peer. To me, it's like opening it up and having other voices reflect on it. And maybe it doesn't mean that they're reflecting on sort of like the scientific rigor of the information, but they might have perspectives to bear as it relates to, information that might be found in the discussion or the introduction where you're contextualizing it, right? Or what it means to them. And we might actually get research that is a little bit more grounded in like what the practitioners and what the people who are impacted by some of these things, what it means to them. Yeah. An area that I'm interested in, but I don't know enough about, so I'm just sort of like watching from a distance, would be like the uses of things like blockchain as it relates to open data, and how we can perhaps share our information in ways that, where we can have like a digital identity, for example, to share information in a way that is a little bit more open, but it sort of addresses some of those issues as it relates to privacy preservation. Yeah. Awesome.
Okay. Usually after academic research is conducted, there may be questions for future research based on or as an extension from what one's research has been. Now, I know you're still in the process of your research, but do you foresee any further research that would not be a part of your scope, but then future researchers could build upon what you're doing to ask further questions?
Yeah, I think my research will be a little bit critical, or at least contextualist, when I get to the qualitative aspects. And I'm not originally a qualitative researcher, but I'm loving where I'm at right now with this. Because I think I'm going to ask really critical questions about the dialogue and the instruments that are being used to maybe potentially control different actors to sort of do things like collect data or report on data in ways that I would say reinforce maybe a dominant narrative of how healthcare should be delivered, and maybe opening that up a little bit and saying, why are all these conversations happening behind closed doors? Yes, we have these arm's length organizations, but the discourse around these issues is very sanitized. So we don't really know the nitty gritty of the things that you discuss there. There's not enough participation at those decision-making tables. So I think my research will open up a lot of critical questions. And I'm excited about that because I do believe that somebody who is very rooted in qualitative critical research will take that and run with it. And it will open up that dialogue about how we're making decisions about the investments in technology that we're making and the critical issues and how we need to engage more within some of these spaces with other folk. And for me personally, the question I think I will only be able to answer from a very short-term lens will be the impact of these tools. Like, I'm really interested in the emancipatory aspects of these tools. I'm interested in the questions around the recovery-based model versus the harm reduction model and that continuum of care and how how the impact that's going to have over time and how these tools play into that. Either how these tools play into how the agencies are able to advocate for reforms, or how these tools maybe directly play into the delivery of care. I think those are longer term questions that can't be answered with my research if I want to finish it within a reasonable amount of time. And that's a good thing. I think when your research generates more questions, it really means that it was meaningful research. So I'm looking forward to that. Whether I answer those questions or someone else does, that's not what matters. It's that the questions are they are brought to the light and that we're trying to answer them.
Yes, absolutely. Awesome. Now let's talk a bit about disseminating research to a broader audience, and you've talked a bit about that already. Can you just share some of the platforms that you've had an opportunity to share your research?
Well, I know this guy, his name is Kwaku, and he has a platform. This is a platform for dissemination of research. You're doing it right now.
Yes.
So here's a great example. And it's accessible, right? So maybe your primary audience, maybe it's faculty, academics, maybe it's graduate students, but there could be a high school student somewhere who's thinking of doing, becoming an academic one day, and they stumble across your podcast on YouTube or wherever it's posted. And so that's making it more accessible in that way, right? And also more representation, because actually, as you and I sit here, we both are of, the Black community. So that's making it more accessible in terms of having more examples. In my field, it's often called use cases, but more examples of how it's being done. It's normalizing it. And it is that. It's very normal. It happens all across the world, happens in other countries where we have Black researchers doing amazing work, and we just need it to be more accessible. In terms of dissemination, I do think that we need more plain language summaries of things. That's certainly an area where when I used to work, we used to engage in pre-processing the evidence. So you would have a systematic review, for example, right? And again, I'm shouting out to health evidence. I'm actually doing a little bit of work, not a lot, a little bit of work with them, which is really exciting. It's very full circle. Because I worked there, as, a knowledge broker, and now I'm coming back in the current, position and role that I'm in to just sort of, maybe see the things I've picked up along the way and to engage in the dialogues of the really amazing work that they're doing. But what we used to do, we used to pre-process the evidence, and we would give the evidence a score. So, whenever there are these dialogues that are happening, there's a lot of misinformation out there. There's a lot of dialogues that are happening. People are picking up these very random studies that are very poor. They're very weak. And for the average person, they don't know that it's weak or why it's weak. And so we would actually give it a quality score to say, this research was conducted very well. And this is what the results mean. And so more plain language, pre-processed summaries, like a lot of what Cochrane reviews do, for example, and more synthesis of evidence. So these individual studies are great, But what's better than an individual study? A lot of individual studies, we put them together and see what they say, right?
Yeah.
So that's just two areas. I probably could go on and on, so I'm just going to stop with those two, and then just sort of say that my philosophy is my philosophy in information management is about the free flow of information in ethical and responsible ways. My philosophy about, research evidence is very much in the same. Let's make it more accessible.
Right. Awesome. My final question, just as you have had people that have inspired you, there are probably people in your past, present, and there will be some in the future who are also looking up to you for inspiration with the path that you've gone on. What advice would you give to somebody who's trying to follow your path to become a professor, a PhD student, whether specifically in health information systems or just generally?
Yeah. Again, I mentioned that I'm a disruptor, so I'm hesitant to be any kind of influencer or for folks to look up to me in the way that I do it, because I'm probably not going to do it the way that most people do it. But I think what I would say is to just build your network and find people like me and other people whose research or their ideology really resonates with you, and get hyper interested in it. Like, learn everything that you can about it. Don't silo your understanding. Look to other types of, have more of a interdisciplinary perspective to things. It'll allow you to engage in different dialogues in different spaces and to bring your research into other spaces. And so, it doesn't mean that you have to know everything about everything, but try to sometimes get outside of your comfort zone. So that would mean mentorship with not just people within your specific specialized area or field, but people that are outside of it that will give you some perspective, right? In terms of my path, it's very, I mentioned earlier, it's not a typical path. I started in practice. I came here to develop, Canada's first health information management accredited program. So that's the first. It's been done. So you might not be able to do that again, but I think you can do some other things. So look at ways in which you can engage in academia that include research, but might also include community. Because as a faculty member, we have to be engaged in community, we have to be engaged in research, and we have to be engaged in teaching. So maybe for you, what really inspires you is the teaching. So maybe you'll be an academic who does more of the teaching. Guess what? You still have to know the research to be able to teach effectively. You have to know the latest evidence. You have to be able to teach effectively. So research is certainly an underpinning, and it will never go away in terms of academia. And then I think finally, I was reading a paper by Stuart Hall on intellectualism versus academic work. And I would encourage folks to focus on the intellectualism. And what that means is maybe you get your PhD, but you don't work in academia. Maybe you get your PhD, but you work in industry. Maybe you get your PhD, but you work in government. And I think all of those can be highly impactful places. We definitely need really inspirational leaders within academia, especially as academia really changes and people are with these courses you can do online and the like. There's just a lot of change that's happening. So we really need really inspirational leadership within academia. But in terms of what really resonates with you, get that PhD, get that master's degree, do that research. Those skills that you learn will be important even if your primary job isn't as a researcher. That makes sense?
Absolutely.
Yeah.
Absolutely. Well, thank you so much, Ramona, for joining us on this podcast. It's been awesome chatting with you about your research.
Absolutely. Thank you, Kwaku. And I look forward to watching this video and all the KT work that you're doing.
Absolutely. Thank you.
Take care.
Yeah. Thank you very much for tuning into the Academic Research Made Simple podcast. Please tune in again to another episode where we discuss more incredible research being done by racialized faculty and racialized graduate students.